All right, let's talk about anemia in pregnancy. So, classification for anemia in pregnancy: hemoglobin less than 11 in the first trimester, 10.5 in the second trimester, and back to 11 in the third trimester. The cutoff for African Americans, hemoglobin is decreased by zero point 0.8. 2% of pregnant women will have iron deficiency anemia. Teens, blacks, multi-pairs are at greater risk. We can categorize anemia in three different ways. Either you can do it inherited versus acquired. We can do underlying cause, mechanism, or cell morphology. Um, I'm more familiar with this cell morphology type category classification. So microcytic anemia, which is MCV volume less than 80. We have iron deficiency anemia, thalassemias, anemia of chronic disease, sideroblastic anemia, anemia associated with copper deficiency, and also lead poisoning. Normocytic MCVs. We have hemorrhagic anemia, early iron deficiency anemia, anemia of chronic disease, anemia associated with bone marrow suppression, chronic renal sufficiency, endocrine dysfunction, autoimmune hemolytic anemia, anemia associated with hypothyroid or hypopituitarism, hereditary spherocytosis, and hemolytic anemia associated with paroxysmal nocturnal hemoglobinuria. Macrocytic, we have folic acid deficiency, anemia associated with vitamin B2, um, drug-induced hemolytic anemia, such as zidovudine, anemia associated with reticulocytosis, liver disease, ethanol abuse, anemia associated with acute oh, acute myelodysplastic syndrome. All right, so um, anemia in pregnancy, the plasma volume in pregnancy expands about 50%, while the erythrocyte mass only expands 20%, which makes you anemic. Um, the total amount of iron in women is 2.3 grams. Iron deficiency anemia, how do you diagnose it? If you have a 1 gram per deciliter increase in your hemoglobin after iron treatment, if you have a absent bone marrow iron store on bone marrow iron smear, or less than 30 microgram per deciliter of ferritin. Management, typical American diet has 15 milligrams of iron per day. Recommended During pregnancy is 25 milligrams per day. So we need to supplement these patients usually with 40 milligrams to 200 milligrams of elemental iron per day. Alternative dosing regimen could be that has possible better reabsorption and tolerance is every other day dosing, um, up to day says 60 milligrams elemental iron Monday, Wednesday, and Friday. So we can give different types of ferritin preparation. So ferrous sulfate is the most common. You can use 325 tablets containing 665 milligrams of elemental iron per tablet. I think this was due to a increase in hepcidin with daily dosing, which will decrease your iron absorption. Um, During lactation, it's recommended to be 5 milligrams per day. So in total, around 1 gram of iron needed from conception to delivery for a normal weighted female. Takes 14 days to see an increase in hemoglobin. IV iron not used in first trimester due to no data on safety. So IV iron can be given to bariatric surgery patients who had a Roux-en-Y, gastric resection, or pancreatic diversions. Ferrogluconate preparation containing benzoyl alcohol preservations should be avoided in pregnancy. Iron sucrose require multiple infusions. Low molecular weight iron dextran, ferromoxitol, and ferric maltose can be given as a single dose. Reticulocytosis can be seen after 1 week. Increase in hemoglobin greater than 1 gram per deciliter after 2 to 3 weeks. Normalize serum ferritin after 3 weeks. Okay, so we have complications of iron deficiency anemia, low birth weight, preterm delivery, perinatal mortality. This is the same I just talked about. Low dose iron supplement is recommended starting in the first trimester. Universally. Macrocytic anemia in the U.S. Most likely pregnancy in the U.S. pregnancy is mostly caused by folic acid deficiency. If deficient, patients should be treated with 1 milligram of folic acid. Other possible cause of macrocytic anemia is B12 deficiency. Screening for anemia should be done twice during pregnancy, one at presentation and the other one at 24 weeks. We talked about thalassemias in the other talk. Blood transfusion should occur if maternal hemoglobin is less than 6 grams per deciliter. This is associated with abnormal fetal oxygenation, low FI, and sometimes fetal death. For postpartum anemia, IV iron at 5 days and 14 days had a greater hemoglobin. However, at 6 weeks postpartum, IV iron showed a 1 gram higher hemoglobin level. Erythropoietin during pregnancy is associated with shorter time to targeted hemoglobin with no additional benefits in postpartum patients.